what are the problems with narcotics? So the first thing that comes to you is that that do I really need to start this? So will I be overdosing the patient with narcotics? When you start to prescribe it, then will this patient of mine just land up at night in respiratory depression, and there'll be a CPR call which will eventually lead to death? Then will there be addiction? If I keep continuing to prescribe this drug to the patient will keep demanding more and more of this drug. Then will this patient does he have a pre-existing psychotic behavior, or is there some psychiatric illness, or will the narcotic lead to a psychiatric illness? Then will I be able to cope with the increasing demand of the patient about the drug? So let's simplify this, as much as we can, because it's very difficult to get into the minds of the patient sometimes. So the approach would be here that anybody can prescribe, any registered medical practitioner can prescribe narcotics, but it should be, the prescription should be safe and effective. So what is very important is that to understand the drug, the adverse effects, especially how it works, what should be the dosage, what should be the timing, the contraindications, and how to monitor this drug, both the adverse effects and the effects of the drug. Then ensuring that you are giving this drug with accuracy, the dose and the timing. Then following all the regulations, one should be aware of the state and the national prescribing regulation. Then considering giving the patient information about the risk and the benefit of this drug, including the side effects, the effect that there could be tolerance and the patient could require a higher dose, or there could be physical dependence, and of course monitoring the drug. So I'm sure we have done this in the, that clinical history is very important, and why we are starting this patient on a narcotic. So it could be either a case of discitis, who will need prolonged painkillers. So we give the benefit of doubt to the patient, in that case. It could be rib fractures or some polytrauma where the patient has pain at multiple areas in the body. So we give the benefit of doubt and we say, yes, okay, this patient is going to require long-term pain relief. So we will, give this patient a narcotic. And then we we assess the pain, that whether this patient has constant pain or is having breakthrough pain even after taking analgesics, and what is the pain score. That is very important, that we keep assessing the pain scores. So it could be either the simple numeric pain scale 0 to 10, or it could be a more elaborate questionnaire like a Megill's pain questionnaire or a brief pain inventory. So that has various aspects of pain, that what makes the pain worse and what makes the pain better. So it's a very elaborate questionnaire. So the approach here would be that there's a 10-hour standard. That means you select, like Samir and others have already said, the how to prescribe. So we need to write the patient's name, the right drug, the dosage, the timing, the route of administration. Now, and the patient has the right to refuse it, especially in a hospital setting, that the patient is due for a drug, a painkiller, but he says, no, I don't want it. So the patient should be given that right, and the right knowledge and the understanding of the drug, and we have to document it properly in the prescription paper. And of course, we already did the history and the assessment, and keep assessing the response of the drug. So appropriate prescribing should be done, especially to avoid addiction, abuse, overdose, diversion, and misuse. So there have to be regular follow-ups once the narcotics have been started. Also when we are prescribing, it should be safe, effective, acceptable, available, and it should be economically viable to the patient. So there's a Narcotic Act which came up in 1985, and this act it has been amended a few times, but mainly it is for that that keeping narcotics which are except for medicinal uses, of course, and in appropriate doses and in small amounts is only allowed. But if somebody is found in possession or sale or purchase, or even the chemist cannot deliver the patient home the drug, somebody has to go and collect it from the patient, from the chemist. So even transport of the drug. So one of my patients came to me and said that no, they're not delivering the drug home. So yes, they will not deliver the narcotic home because you have to go and collect it yourself along with the prescription. And one has to give triplicate prescriptions. So 3 copies of the prescription have to be made with the name, with the hospital identity number, and with a small brief diagnosis. It has to be dated properly, and the dose has to be written appropriately. I mean, not SOS or something, 3 times a day. It has to be written, and how, before lunch, before breakfast, it has to be written, and for how much duration you are going to put it, for 1 month or something, or 15 days. So, and but in certain countries where I was working in Singapore, you had to actually write that, how below that you had to write how many drugs to be given, how many tablets of that morphine 10 mg to be given to the patient, or how many patches you have to give. So over and above, like 3 times a day, 1 month, you had to write down, please give 90 tablets only to the patient. And then it has to be signed with a stamp and with the registration number of the doctor. And when the patient goes with this prescription to the chemist, they ask for Aadhaar card or a passport of the patient, and 1 copy goes to the Narcotics Bureau, 1 the chemist keeps, and the other one is given to the patient with stamped, and the chemist writes on it, on the stamp, how many drugs, how many tablets he has given to the patient. So supposing the chemist doesn't have 1 month stock, has only 15 days stock. So if it is 3 times a day, 90 tablets, the chemist has only given 40 tablets to the patient. So he will write on that only 40 tablets were given to the patient. So it's quite strict, these narcotics. So now coming to the weak opioids. So we have weak and we have strong opioids. So among the weak opioids, we commonly use tramadol, tapentadol, and codeine. Codeine is not very popular somehow in our country, but it is quite popular in other parts of the world. So we know tramadol, it is a serotonin norepinephrine reuptake inhibitor. It has some opioid receptor activity also. So these opioid drugs work on the mu receptors, and these mu receptors are pain receptors that are present in the brain and in the spinal cord. So tramadol can be used orally, intravenously, and intramuscularly. So it's important to know the bioavailability, which is that when you take a tablet, how much of it actually reaches the bloodstream. So when you take it orally, it is 68%, rectally 77%, and intramuscularly 100% of the drug reaches in the bloodstream. And duration of action is 6 hours. So tramadol can be given every 6 hours. So it can be actually given 4 times a day in doses of 50 to 100 mg. You can divide it. So again, this is tramadol comes popularly in combination with paracetamol. So but if I have to see this patient, and if I want to increase only tramadol and not the paracetamol, because of different ways in which they both work, so I would prefer splitting the drugs. Give separate paracetamol, Lanol, or 1 gram 4 times a day, and give separately tramadol 100 mg a day for a 70 kilo patient. That's the way I would work, so that the patient has the choice of which drug is working better and can decide. The next drug is tapentadol. This is popularly, it comes as it's mainly oral, and even intranasal is available, and intranasal works quite well because it's quite rapidly acting. So if the patient has acute pain, they can take intranasal. So 50 mg is the dose, 50 mg twice a day usually it is given. And and 1 spray, patient takes 1 spray, it is around, so patient can take about 2 sprays at a time, so 22.5 mg per spray it's available. So next, coming to the strong opioids. So we know that morphine is the gold standard in opioids. So we have the opioid receptors, and God gave us this medicine which was naturally cultivated over centuries. It has been cultivated. So we have that as immediate release, sustained release, and it is available in injectable form as well. So morphine, if I have to give patient morphine, I would start either with 10 mg twice a day, depending on how much tramadol the patient is on. So for 100 mg tramadol, you would give 10 mg of morphine. So if I have to start morphine on a patient, you would start 10 mg every 4 hours. So the patient has option of taking it every 4 hours, so 6 tablets a day. And if the patient has taken 6 tablets a day, that is 60 mg, you can later on divide it into the next day as 20 mg TDS. So without knowing the daily dose of a narcotic, we cannot give a blanket prescription of 3 times a day or 4 times a day. We cannot there's no fixed doses. Do I have 5 minutes more? I can take 2-3 minutes more. Yeah, okay. So then we have fentanyl. Now fentanyl, I would like to say it's available in patch form, and there is no role of patches in acute pain. We have the habit that post-surgical pain also people give fentanyl patch or buprenorphine patch, but without knowing the daily dose, you should not be giving a patch, because you will be giving a 25 microgram patch which will go on incessantly. It will go on, 25 microgram will be given to the patient without knowing the daily dose. But yes, if you have given a PCA to a patient and then that PCA you want to convert to a fentanyl, that is possible if the patient has, we are going to expect long-term pain for the patient, supposing it's a rib fracture or some major surgery. So then we can then give fentanyl patches. Now same with the buprenorphine patch, but the catch here in the buprenorphine patch is that it's a mixed agonist and antagonist. Means it is an agonist on the mu receptor as well as it is an antagonist. So when you have put the, so people find it's actually safer in that way because it does not cause so many harmful effects of a pure mu agonist like a morphine or a fentanyl. So it is preferred because the respiratory depression and all is much less. But the catch here is that if the patient has breakthrough pain in between the patch, then if you are going to give a pure mu agonist like a tramadol or tapentadol, that will not work to that extent because this buprenorphine will be antagonizing the morphine that you give at the mu receptor. So therefore, in practice, buprenorphine and these patches are not very popular, especially in the Western world, because people prefer pure mu agonists. So now just talking about the adverse effects which we should know about the narcotics. Nausea, vomiting is very common. Constipation is something very common with them, and there's no tolerance that happens with constipation. Constipation is not something that the patient will get used to. It will happen and it will always happen. It will always stay. Then the other things are dizziness, dry mouth, indigestion, vertigo, headache, and in worst case scenario, respiratory depression. So we should, to adequately control the pain, we should have a framework for writing prescriptions. We should have a fixed dose regime. Then we should give something for breakthrough pain. And we should know how to convert one opioid to another opioid, that is opioid switching, in case the previous opioid is not working or there's tolerance to the previous opioid. And one needs to know how to titrate the doses and understand the issues of substance abuse. This is my last slide about something like a narcotic contract. Now, if a patient is on a long-term narcotic, that needs to be something that we need to put in, that is a narcotic contract, that's a pain contract, in which there's an agreement between the patient and the physician about about outlining and about knowing that how we are going to go about with this treatment. So there has to be a promise that there'll not be any sharing of medication, that you cannot give your morphine to somebody else, that your family member has a headache and you give your morphine to that person. Then a promise that not to use illegally these drugs. Then a promise that the medication will be used only as prescribed and there'll be no overdosing on the medication. And the patient has to be ready anytime for drug testing or pill count. You can call them anytime for that. And so this helps in, if there's any violation of this contract, the physician can stop giving the drugs to the patient. And the purpose of this contract is to improve the care and increase the adherence to the opioid therapy. Thank you.
Thank you, Preeti.